morning, everybody. Thank you, BSSCON, for providing me this opportunity. I'm here to present our research work published in Global Spine Journal in 2020. To declare, we have no conflict of interest and we did not receive any financial support for the research. Osteoporotic vertebral fractures remains an enigma to the surgeon till date. And previously published reports have shown that incomplete neurological deficit following the vertebral collapse can be due to retropulsed bone fragments, progression of the kyphotic deformity, or instability at the fracture site. And also previously published literature reports that fractured vertebrae gradually undergoes remodeling and normal anatomy of the spinal canal is regained with time. Hence, the role of neural decompression is debatable. So in this study, our objective was to analyze the outcomes of treating osteoporotic thoracolumbar fractures with incomplete neurological deficits by posterior instrumentation without neural decompression. We hypothesized that instability at the fracture site rather than the neural compression is the main factor leading to neurological deficits in patients with OVCFs. And we have done this using a dynamic MRI imaging. In the material and methods, it was a prospective cohort study and approval from the institutional review board was taken, and data of the patients was collected from January 2015 to December 2017. Of the total 204 patients we had after exclusion, 61 patients were included in the study, and dynamic MRI was performed. As you can see in the imaging, we have used a cushion to create a flexion and an extension at the thoracolumbar spine to obtain the images as evident on the image. So demographic data of all the patients, including age, sex, comorbidities, and medications that led to secondary osteoporosis and number of vertebral fractures and levels involved were collected, and post-operatively anterior osteoporotic treatment taken by the patients and incidence of new fractures was also taken. Pre-operative and post-operative neurological status was assessed using INSCI. And radiographic assessment was done as seen on the image using the method of Lieberman and Cobbs. This is a sample image showing the dynamic MRI, wherein you can see compression on the flexion and the relief of the spinal cord compression on the extension images. And we have used the cement augmented fixation for this particular case, and we have not decompressed the patient. And statistical analysis was performed using the SPSS software. And as you can see on the screen, there were 39 non-walkers and 22 walkers, and around 40 females and 21 males were included in the study. And 6 people were on steroids for the other diseases which cause secondary osteoporosis, and 2 patients were excluded as they required revision surgery due to implant failure. And in 18 of the patients, we had to use cement augmented fixation. Of them, 11 were long segment and 6 were short segment. In the present study, all the patients showed spinal cord compression on flexion MRI, which was relieved on extension, as evident by restoration of the spinal canal alignment and cerebrospinal fluid column restoration. A total of 65.56% did not show any significant compression on neutral MRI, and nearly majority of them have regained their neurological status at final follow-up. And there were 2 episodes of wound dehiscence which healed by secondary suturing, and rod breakage was seen in one case, which was excluded from the study. Traditional MRI may underestimate the severity of the pathological fractures, especially at the dorsal-lumbar junction, and dynamic MRI is a valuable adaptation of the conventional MRI. In our study, dynamic MRI confirmed the hypothesis of dynamic instability. All of them showed significant retropulsion and compression of spinal cord flexion, which relieved on extension with restoration of the CSF column. And the reason for the delayed neurological deficits was dynamic instability caused by repeated micro trauma rather than the static mechanical compression. The simple posterior fixation without decompression is not only technically easier but also safer. The risks of anterior approach and potential damage to neural tissue from the decompressive procedure can be avoided. The surgical time, blood loss, and operative morbidity are reduced. Posterior elements maintain spinal stability are preserved, and adequate space is available for bone grafting. We have few limitations in this study. It is not an RCT or a carefully matched cohort study. Our study population was relatively heterogeneous, as there was a lack of control group or continuous BMD monitoring, and it was a limited sample size, restricting our ability to separately analyze the cement augmented versus non-augmented screws. However, it is the largest series of the osteoporotic vertebral compression fractures with neurological deficit managed by fixation only. In conclusion, our results indicate that posterior instrumented fusion without neural decompression leads to neurological improvement. We propose that neural decompression of the spinal cord is not always necessary for the treatment of neurological impairment in patients with osteoporotic vertebral collapse with dynamic mobility. Dynamic MRI is a valuable tool to make an accurate diagnosis and determine precise surgical plan and improve the surgical strategy of the osteoporotic vertebral compression fractures. Thank you.